Welcome to the Get Ahead of the Stroke Campaign Media Briefing. During the presentation, all participants will be in a listen-only mode. Should you wish to ask a question during the presentation, please use the chat feature located in the lower left-hand corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Wednesday, May 25th, 2016. I would now like to turn the conference over to Marie Williams, the Executive Director of Society of NeuroInterventional Surgery. Please go ahead.
Thank you. Today we are going to explore issues associated with stroke mortality and patient recovery, standards of care for stroke patients, and policy solutions that have the potential to save as many as 65,000 lives per year. I am pleased to have with me a panel of experts in ischemic stroke, endovascular stroke therapies, and the policy solutions that are necessary for patients to have access to 24/7, 365 endovascular treatment. I'd like to introduce our panelists. Donald Fry is a neurointerventional surgeon with Radiology Imaging Associates in Denver, Colorado. Blaise Baxter is an interventional neuroradiologist at Erlanger Health System in Chattanooga, Tennessee. Mahesh Jayaraman is an interventional neuroradiologist at Rhode Island Hospital and Brown University in Providence, Rhode Island. And during the Q&A portion, we will also be joined by Michael Chen, an interventional neurologist at Rush University Medical Center in Chicago. Dr. Fry, I think it's safe to say that stroke is something everyone is familiar with. It's a leading cause of death and disability, and many of us most likely know someone who has experienced a stroke. Can you help us understand stroke's impact?
Thank you, Marie. Stroke is extremely common, and unfortunately in the USA, the incidence keeps rising every year. It is a leading cause of death in the U.S. and is the #1 cause of adult disability in the USA. The cost of the stroke is staggering, costing healthcare dollars in the U.S. more than $34 billion per year, and unfortunately those numbers keep going up as well. There are some misperceptions about stroke that I'd like to mention. Stroke patients can get better if they get the right treatment rapidly, and stroke does not only affect the elderly but affects all age groups. In fact, the incidence of ischemic stroke in younger age groups has been going up over the last few decades. Emergent large vessel occlusion, ELVO, is a stroke caused by a large artery in the brain that's blocking. It's the most deadly form of ischemic stroke, and we now have cutting-edge procedures that have recently been published that prove that this can reduce stroke mortality by up to 50% if the patient gets to the right center and is treated by the right physician very quickly.
What is the current treatment protocol for stroke patients?
Right now, EMS sees, the first responders see a stroke patient or a suspected stroke patient in the field, and they usually bring that patient to the nearest hospital. Now, that's a good idea if that patient is administered inside the artery IV TPA treatment, but the most dangerous strokes, secondary to ELVO or large vessel occlusion, need to get to the nearest neurointerventional surgery-capable hospital where a stroke surgeon is trained to pull that clot out of that person's artery as fast as possible, and that's not the current protocol, and that's what we need to change. Not every hospital has that type of capacity, so we have to make sure our first responders know where those hospitals are, where those stroke surgeons are, and know what patients to bring to those hospitals.
Is there a more effective way to treat stroke that can improve patients' odds of surviving and recovering from a stroke?
Absolutely. I think the large vessel occlusion strokes are the most deadly, and they can cause death or disability in 3/4 of those patients. The inside the artery therapy is minimally invasive. It's delivered, a small catheter is delivered to a hip artery by a stroke surgeon into the artery in the brain that's blocked, and special devices are used to remove the clot from that person's artery in the brain. And that is the best way to get that patient back to independence, is by restoring the blood flow. This can reverse those patients' symptoms, can decrease mortality by up to half, and can save billions of healthcare dollars per year in the USA. And amazingly, when you block the blood flow to someone's brain, 2 million neurons die per minute if that stroke goes untreated, which is staggering. If we can get those patients' arteries open as fast as possible, preferably well within 6 hours of symptom onset, we can reduce mortality by half and improve life expectancy by up to 5 years.
Fantastic. Dr. Baxter, could you explain to us why so few patients receive endovascular treatment if it's so effective?
Sure, Marie. Yeah. Well, we have this incredible treatment, and we really know how to treat our stroke patients swiftly and effectively. The availability of our healthcare facilities with the means and wherewithal to really care for these acute stroke patients varies vastly from state to state. So this is very frustrating, obviously, since endovascular treatment for large vessel occlusion does more than just save lives. As has been mentioned, stroke is very expensive, costing the U.S. about $34 billion in healthcare annually. So endovascular treatment also makes financial sense. So a growing trend in addressing these issues concerning the stroke patients is states developing stroke systems of care. And this is a comprehensive, extensive system of policies and protocols that address all the aspects of stroke care. And despite this focus, so fewer than half of these states have any legislation that establishes stroke systems of care. In states that do, most of the legislation is dated and doesn't really align with the best standards of care. So one of the overall impacts of this campaign is really that we want to improve these systems of care. They've not kept pace in treating our stroke patients, and they're not as well coordinated as they need to be. So I think we'll take a look at really what is possible when a patient does receive quick endovascular treatment. This is a young patient. We're going to see a video that was treated at our facility, and unfortunately, for some unknown reason, the incidence of stroke in young patients is actually increasing within the country. So this is unfortunately not an uncommon scenario where we see a very young patient very devastated by a large vessel occlusion stroke.
Valerie, I want you to tell me, what is your name? Big smile. Show me your teeth like this. Good. She's very weak on the right face. Let's take a look at your arms, Valerie. Raise this leg here for me. Raise this leg. Good. Raise this leg for me here. Valerie, tell me, how are you doing?
I'm good.
Arms up. Raise those arms up for me.
I'm good.
Fantastic. Let me see you walk over there towards the wall. Super. Hey, you just look great. Well, look, you keep doing your therapy. I'm glad that you're doing so great.
Well, as we can see, as I say, a picture paints 1,000 words. As the video tells the story of what an incredible impact this therapy has in changing someone's life. A young patient that would be permanently disabled and maybe even die from the stroke can go on and independently live and contribute to society. So that's we were able to obviously effectively treat her, and this is what we hope to have disseminate through the rest of the country.
Wow, thanks for sharing that patient story, Dr. Baxter. What needs to change so that more people can have outcomes like Valerie's?
Yeah, well, as we said, we really need to educate first responders about uniform stroke triage, in which they automatically send these patients to the types of facilities where that care can be delivered. Patients treated quickly are more than twice as likely to have a better outcome than those who are not. We need to build in our capacity in hospitals to establish these really truly comprehensive stroke centers that are equipped with the proper technology, devices, qualified medical personnel, as well as the understanding in what are the best and optimal treatment protocols for their patients. We need to ensure that there are neurointerventional ready hospitals that have the staffing, the qualified doctors, the on-call personnel that can do this 24/7, 365 days a year. So that's a very important piece of this. We also, to meet all these needs, we really, our Society of NeuroInterventional Surgery and its partners are launching this major, campaign. So our partners are the hospitals, healthcare organizers, and others. And the campaign is going to be titled "Get Ahead of Stroke." Get Ahead of Stroke is a national public education and advocacy campaign designed to improve systems of care for stroke patients. The number one call to action really is to enact legislation. As we've talked about, the states really have lagged behind in having any formal kind of policies. So we'd like to enact legislation in all 50 states that really requires EMS to divert ischemic stroke patients experiencing emergent large vessel occlusion to these neurointerventional ready hospitals that provide the 24/7, 365 coverage to deliver the proper care to these patients.
Great. Thanks so much, Dr. Baxter. Dr. Jayaraman, this seems like a big ship to turn. What precedents exist for creating legislative models that support stroke systems of care and improve patient outcomes?
Thanks, Marie. That's a great question. As you've heard, we now have an incredibly effective treatment for the most disabling type of stroke, one that would ordinarily leave 3/4 of patients dead or disabled. There are other similar diseases where there is an extremely time-sensitive nature. So, for example, if a patient is in a severe motor vehicle accident or some other type of severe trauma, those patients are taken directly to what's called a level 1 trauma center, as opposed to a lower-level trauma center. And we think that that paradigm and that precedent needs to extend to stroke as well. It's not reasonable to expect every hospital, and it doesn't need to be that every hospital provides these services, but instead what we need to do is to teach EMS how to screen and how to transfer the appropriate patient so that the right patient gets to the right hospital the first time. We're fortunate enough in Rhode Island to have done just that. After these last 5 dramatic trials showed a substantial benefit to embolectomy, we have enacted statewide legislation that recognizes that there are comprehensive level centers that have 24/7 neurointerventional coverage with physicians and teams of nurses, technologists, and others who are ready to do these procedures at a moment's notice. Once a patient is picked up in the field and identified as suspected of having one of these types of severe strokes, patients, if they're within a reasonable transport time, will go straight to the neurointerventional capable center so they can get this life-saving stroke surgery as soon as possible. I think another key aspect of that legislative change is understanding that we need to put aside political barriers, we need to work together through multiple disparate hospital systems, and we need to also work across state lines. In some cases, the closest and most appropriate hospital for a patient to be transported to may be across a state line. Certainly for level 1 trauma, we would transport that patient, so why wouldn't we do the exact same for stroke?
Great. Thank you so much, and thank you all for your insights. Now we're going to go ahead and open up for questions. So my first question to all the panelists would be, what would you say is the biggest barrier to states implementing these policy changes, and how does the campaign plan to address it?
Well, this is Don Fry. I would say education. We need to educate our EMS directors, our state health departments and legislators that this therapy really works. If you get that patient to me, I'm going to get that patient's artery open quickly, and they're going to get better and go home. That's their best chance. And we just don't have all of these folks involved in making this happen just don't know about this yet. So we really have to educate people as fast as possible, because stroke occurs every 40 seconds. Someone's having a stroke. We can change that. And it's Blaise Baxter. We do have enough treatment capability. Really, another thing that's a major challenge of this is just a matter of how we organize the systems of care to have our patients delivered to receive this effective, and treat the effective treatment as quickly as they can possibly be treated. So getting this advocacy at a national level and helping the states see a roadmap and a plan to how they can organize and deliver the systems of care is, I think, our next big challenge.
This is Mahesh Jayaraman. I'll follow up on what Don said. I think it's really education. I think that when it comes to certain diseases like heart attack, people know that there are minor heart attacks and major heart attacks. I think that unfortunately for stroke, people think that stroke is stroke. And we need to have the first responders and all of the people involved understand that these elbow strokes, these large vessel occlusion strokes, really account for the majority of disability that comes from stroke. And for that, we now have an incredibly effective therapy. So I really think it's sort of getting people to think about stroke, not just as, every stroke is the same, but could this be an elbow stroke? Could this be one of those really deadly and disabling strokes?
Great, thank you. Operator, could you please remind all the participants how to ask their questions? And in the meantime, we do have a question from one of the participants. Dr. Baxter, is there a huge racial disparity when it comes to stroke recovery and survival?
We do not, see that. I'm practicing in the Southeast, and in our facility, it's a pretty, homogeneous, outcomes from treatments and in recovery. So we do not see that as a problem where we're, treating our stroke patients.
As a follow-up to that, are most of the people in the United States within a reasonable time period of a neurointerventional ready hospital?
Yes, absolutely. I think there's been studies done to look at that and to address, do we have the the workforce, the manpower, so to speak, to deliver this care, and we do have that within our body of neurointerventional surgeons that's made up of multidisciplinary neurology, neuroradiology, and neurosurgery. We have enough expert neurointerventionalists throughout the country to, that patients can be brought to these high-level comprehensive stroke centers in an effective time, or to have their treatment delivered.
Great, thank you. Operator, could you please inform everyone how to ask questions?
Please use the chat feature located in the left-hand corner of your screen.
Great, thank you. We have another question. Let me give this one to Dr. Chen. In your opinion, what is the first step states need to take in determining the policy changes needed to better ensure stroke patient outcomes?
Thank you, Marie. I think this is a very challenging topic. There actually is some history leading up to this. The only proven therapy for acute stroke prior to 2015 was intravenous TPA delivered through an IV line, and as a result, a lot of the stroke systems of care was somewhat decentralized with multiple what's called primary stroke centers. But since then, now since 2015, with this proven therapy, I think there's an additional level of complexity outlined very well by my colleagues with regards to proper first responder education, as well as legislation that helps first responders have protocols such that they know exactly where they need to bring patients that they suspect have a large vessel occlusion. So there's very little thought or decision making that's necessary. That's all planned out. I think the more that we can protocolize the care, so much of the care of these patients in the hospital is already protocolized, and we can do that sort of pre-hospital. I think that'll further help. And just like Dr. Had mentioned before, that there's a lot of potential politics involved, a lot of interests, a lot of stakeholders. But I think there are ways to negotiate and find solutions that benefit everybody.
Great, thank you. We have another question. Dr. Fry, will most insurance plans, including Medicare and Medicaid, cover endovascular treatment?
Absolutely. All insurance covers this. This treatment is so incredibly effective, it would save us billions of dollars in healthcare costs per year. So it makes sense for everyone, including the insurance companies, to embrace this, and they have. They pay for this. It is incredibly cost savings to do this.
Okay. Great. Thank you, everybody, for your time today. I think we've got one more patient video that we're going to show, and it's Dr. Baxter's patient. So, Dr. Baxter, can you kind of outline what Cassandra came in with and her treatment?
Sure. Again, another young patient that was coming in with a stroke. Again, a very devastating stroke. She was unable to speak, and you'll see she's paralyzed. So the first video is from her being just placed actually on our procedural table and being examined, and then just almost immediately after the procedure, she starts to improve. So we'll start with her initial video.
Great.
Great. Where are you? Do you know where you are? Do you know what happened to you this morning?
No. right? Can you raise this hand over here? Raise this hand for me. Okay, that's good. How about raising this hand? Can you raise this one for me?
You see this is,
Raise it in the air,
this arm
okay?
is paralyzed.
Okay. Let's get your legs. How about your legs? Can you raise your legs for me? That's good. Raise the other one for me, okay? Can you raise this one?
And no movement in the right
Okay,
side.
ma'am, we're going to get you fixed up, okay? Ma'am, can you tell me your name?
Sandra.
Okay. And how old are you?
32.
32, okay. Let's see that arm strength, okay? Can you lift those hands right up into the sky? Great. Hey, give me a good handshake here, good grip. Okay, that's perfect. Well, ma'am, you're doing great, okay?
And again, I think these patient videos that show the impact of this therapy, it's really almost, kind of miraculous what outcomes can happen for these patients and how highly impactful that is, obviously, for the rest of their lives. And so this is such a worthwhile campaign, and so that's why we're, very, very eager to get the word out there, as people have said, to educate, the public as to what is available to them from stroke therapy.
Great. Those videos are really, really impactful. As we close out, I wanted to see if you had anything else to add. I'm going to start with Dr. Chen.
The only thing, I would just like to add is I feel like there's been, just like Dr. Baxter had mentioned before, there's so much, varying levels of progress from a state-to-state level, but I feel like there have been a few states, including Rhode Island and even in Illinois, that we've made a lot of progress. A lot of people are very dedicated over a considerable amount of time to really get the legislation so that patients can be transported directly to where they need to get the type of care that they need. If this system is not made so efficient, precious time is lost, the brain is holding its breath, and the injury may become irreversible, and that's what we are all trying to sort of fight against.
Thank you. Dr. Jayarama?
So I just would like to say, we already do this for level 1 trauma, which is extremely time sensitive. We already do this for severe heart attack, which is extremely time sensitive. But the brain dies faster than any other organ. So we already do those types of maneuvers where we're transporting patients directly to the right center for those 2 time-critical illnesses. Isn't the time we did this throughout our entire country for stroke?
Dr. Baxter?
Yeah, well, I would just like to thank everyone that is listening and is on this call, because I think you're the folks that can take this message and basically disseminate it for us. So it's as you've seen, it's definitely a worthwhile story. It's something that we've been privileged to see a radical change in the treatment for stroke happen during our careers, and so it's a very exciting story to carry out there. And so, like I said, we really appreciate your help in getting that news, to the country.
Great, and we'll close out with Dr. Fry.
As a stroke surgeon that treats patients with large vessel occlusion, we are ready and waiting to have these patients come to us so we can get those arteries open as fast as possible, because time lost is brain lost, and we don't want that.
Excellent. Well, thank you again, everyone, for your time, and we appreciate it. We will be sending out more information as the campaign progresses, and to learn more, go to getaheadofstroke.org, and you can download our fact sheet and take the pledge to help us get ahead of stroke. Thank you all.